Assalamu alaikum. It's a pleasure to be here, Mr. Chairman, and thank you for organizing committee for the kind invite. And it's always a pleasure to be here among friends and colleagues. My task today is to talk about new updates in acute coronary syndrome. So I'm going to do a little bit of an overview. There's not going to be a focal topic, and we'll try to hit the highlights. We'll talk about the spectrum of ACS, which you all are aware of. We'll talk about recent trials in early invasive strategy, trials for vascular access for PCI. Antiplatelet therapy the topic has already been discussed, so I'm going to hit a couple of slides on this, but I'm not going to expand. Antithrombotic therapy, use of bivalirudin versus heparin, and then complete revascularization or not. So, and at the end, if we have time, I have an interesting case to share with you guys. So, let's go very quickly. So, there's a spectrum of acute coronary syndrome, which encompasses unstable angina, non-STEMI, and extends all the way to acute occlusion with ST elevation MI. And we know that this is basically because of an unstable plaque and acute thrombosis. It's important to remember that unstable angina or acute coronary syndrome is caused by lesions that are usually less than 70%. So these are not tight lesions that you see on an angiogram. And as you can see in this series, only about 25% had stenosis greater than 70% on a previous angiogram in patients who presented with acute coronary syndrome. And the data is very, very, very rich in studies that support early invasive strategy in patients who present with acute coronary syndrome. That's been evaluated, and the benefit is mostly derived by the reduction of myocardial infarction. So if you go in early, you stent it, you fix the problem, you have less recurrent myocardial infarction, less recurrent rehospitalization. A recent trial published in 2018 was the VERDICT trial. And this randomized patients to very early intervention versus intervention within the initial hospitalization within 24 to 72 hours. And this is basically targeting the patients who come in on a Friday afternoon with acute coronary syndrome, a positive troponin, and whether you should take them to the cath lab that Friday night or can you stabilize them over the weekend and take them Monday morning. So it turns out that there's no significant difference between the two strategies. You can take them very early, but if they're stable enough, you can actually wait on appropriate medical therapy and then go to the cath lab within 72 hours. The caveat here is that they have to be low risk. And you can see here elevated troponins, elevated gray score, and anti-wave changes fared better if they went to the cath lab earlier. This is known data, but again, it's validated now by a recent trial called the VERDICT trial. Antiplatelet therapy. Plato trial evaluated ticagrelor versus clopidogrel. And we know that in patients with acute coronary syndrome or STEMI, ticagrelor is a stronger antiplatelet therapy and does better with patients who have these presentations. And it's very nice to show that there's significant reduction in ischemic events without actually paying a price with increased bleeding. And this appeared to be the sweet spot where the Plato trial had reduction in ischemia with no increased bleeding. But that's not the whole story. The ISA REACT was just released. And this actually looked at ticagrelor versus prasugrel. And as you can see here, prasugrel, although did not do very well in the TRICON-TIMI 38 with increased bleeding, it did very well against ticagrelor. Interestingly enough, this study was actually funded by the ticagrelor company, who went against prasugrel, trying to show that they're better. In fact, prasugrel had significantly less ischemic events and no increase in bleeding. So it's quite interesting that now, after all these trials have come around, head-to-head comparison between ticagrelor and prasugrel in patients with ACS going for angioplasty shows that prasugrel actually fares better compared to ticagrelor. The ISA REACT is fairly new. The champion is a study of Cangalor, and this was mentioned. Cangalor is an IV infusion, and it achieves very high concentrations in the plasma and inhibits platelets very, very, very strongly and acutely. The nice thing about it is that once you shut it off, it wears off within 2 hours. This is extremely important in patients who you believe may be candidates for CABG, because if you load them with ticagrelor, my surgeons will sit on the patient for 5 days waiting for the ticagrelor or the Plavix to wear off. This is an option where you can actually infuse the drug. You take them to the cath lab, you do the angiogram. If they end up with an angioplasty, you have significant reduction in stent thrombosis and MI. But if you need to get him CABG, you stop the infusion, and within 2 hours, the medicine is done, platelets are active again, and they can go to CABG without further delay. Unfortunately, it's quite expensive, and I don't have it in my hospital, so I don't have a lot of experience personally using this. Switching gears to STEMIs. We know that door-to-balloon time is a very important fact, and for every delay of 30 minutes, we increase 7.5% mortality, and it's important that this slide shows that the delay in door-to-balloon time has long-lasting effects up to 10 years. This is not a 30-day mortality, this is not in-hospital mortality, this is not 1 year. If you delay door-to-balloon time, you will have lasting effects up to 10 years. So this sort of concept is validated and very, very strong. Now, what happens if patient presents to an out of the hospital without cath lab support, without PCI capabilities? And this is the transfer AMI, and as you all know, the pharmacoinvasive strategy was based on the transfer AMI, and you actually thrombolize these patients, and you ship them to a PCI-capable hospital or routine early PCI within the first 72 hours after complete fibrinolytic therapy and revascularization showed significant benefit compared to standard therapy, which was fibrinolytic therapy, stress them, send them home, and see how they do. Routine early PCI is significantly better. So patients who present to an out of PCI-capable hospital cannot be transferred in time, should get fibrinolytic therapy, and then should be transferred to a PCI-capable hospital. Vascular access, switching gears. How many of us actually routinely do radial access for ACS and STEMI patients? Routine. Okay. In my cath lab, 95% of the cases are radial. And we made that switch because of data like this, where in STEMI patients, there's significant reduction in primary outcome, death, MI, or stroke, and actual death. There is a mortality benefit for radial access in STEMI patients. So radial access is our default access for patients who present with STEMI, unless they have cardiogenic shock, and we'll talk about this a little later during the presentation. The MATRIX program was a 2x2 factorial design looking at radial versus femoral, and also bivalirudin versus unfractionated heparin, which is a segue to antithrombotics. And as you will expect, radial access did fairly better compared to femoral in all endpoints with MACE, bleeding, death, or significant bleeding. So radial clearly is better. Moving on to antithrombotics. How does bivalirudin do against unfractionated heparin? As you can see here, there's significant benefit to bivalirudin in terms of death and bleeding as compared to unfractionated heparin. And we know this data because we know the Horizons primary PCI study that actually compared bivalirudin to heparin and 2B3A. And as you can see here, the composite endpoint is significantly better in favor of bivalirudin, and the major bleeding is higher in the heparin arm. This also translated to a significant reduction in cardiac deaths based on the bivalirudin use. So based on the Horizon AMI, we switched all our STEMIs to getting bivalirudin in the emergency room. But that was not the end of the story, because heat primary PCI came behind that. And as you can see here, this randomized patients, about 2,000 patients in England, to radial versus to bivalirudin versus unfractionated heparin. And as you can see here, heparin did better in the ischemic event and did no worse in the bleeding event. It's important to remember that in this trial, most of the patients had radial access for the angioplasty as compared to Horizons. So if you take away the bleeding using radial mostly, then the benefit is actually in favor of heparin, because if you remember in the Horizons, there was an incidence of early stent thrombosis with bivalirudin that necessitated extending the bivalirudin infusion a little beyond the initial primary angioplasty. So again, heparin now is better in ischemic events with no extra bleeding. So because of this and multiple other trials, and because bivalirudin is expensive and difficult to mix, we have now shifted back to heparin for our primary PCI, plus or minus 2B3A as bailout strategy. And as you can see here, for primary effective outcomes, there was significant reduction in favor of heparin, but no bleeding price to pay. P value, no difference. All right, the complete trial. So you take somebody with a STEMI to the cath lab, and you've seen all these cases today, multi-vessel PCI, multi-vessel disease, and a culprit lesion. Do you actually tackle the culprit only, or do you tackle the multiple vessel PCI to achieve complete revascularization? And as you can see here, culprit vessel only was worse than complete revascularization. Complete revascularization achieved significant reduction in composite endpoints, especially in cardiovascular death, MI, or revascularization. This was better. But this is not true if you have shock. If you present cardiogenic shock and multivessel disease, actually, if you do multivessel PCI, you actually fare worse, and there is increased death from any cause if you tackle multivessel disease in a STEMI with cardiogenic shock. Interesting. So we'll zip through this because this is not. But if you actually take a patient with shock with a STEMI and you do support with Impella support before the PCI, you actually increase your survival from about 40%, 50% to 77%. And this has been shown in the Detroit initiative. And I'm stuck. Thank you. This is interesting data showing that if you actually unload the ventricle with an occluded artery and wait for 30 minutes, you have a smaller infarct size compared to unloading or reperfusion alone. You wait 30 minutes with an occluded artery. And they translated this to a randomized trial, 25 patients in each arm, unload with immediate revascularization and unload with delayed revascularization in 30 minutes, no price to pay in the size of myocardial infarction. So unloading the ventricle actually protects patients. And now this is the new pivotal trial, door to unload, and this is the new thing in ACS, where you actually have a patient with an anterior STEMI. You either take him to the immediate PCI, like you usually do, or you take him and you put an Impella in him, and you wait and watch the occluded LAD for 30 minutes without intervention. And then you intervene and open up the LAD after 3 minutes of unloading. And this is something that is actually in the works. It's being, centers are being recruited, and we're going to be center of that. This is a patient that presented with a STEMI. This is a guy who had a previous LAD stent. He went for a colonoscopy earlier that day. They stopped his dual antiplatelet therapy, and then he presented with an ST elevation MI, cardiogenic shock, blood pressure of 80. And the guy looked at this, and what would you do? Anybody? Double wire. So this is a guy who's hypotensive, has a no LAD, ostial circumflex, large dominant circumflex. Would you consider support? Okay, who would do Impella? Okay, perfect. So the next picture. This was not done in our hospital. This is the attempt to place an Impella. So although Impella is very useful and is very helpful, you have to be very cognizant of challenges with vascular access with Impella, because this operator apparently lost the wire and pushed that Impella through a calcified tortuous iliac into the pelvis outside the iliac artery. And then he was very uncomfortable treating the LAD, and then he shipped the patient without intervention. So we took the patient, we opened up the LAD and the circumflex, double wire. We did all that. We stented the circumflex first, and then we stented the done, wide open, wide open. Now the patient is still in shock. What would you do now? You already dissected one iliac. So axillary access, percutaneous, and there you go. The wire goes from the axillary into the ventricle, and then an Impella goes in. And as you can see, the hands are there for CPR. Patient coded. The Impella saved him. He was transported with a mean pressure of 60 to the CCU. Unfortunately, his pH was 6.5 because of the ischemic leg, and the vascular surgeons did not dare to touch him in the setting of a cardiac shock, and he passed the next morning because of severe acidosis and metabolic derangements. So, on a good note, I will end my talk, and I'm happy to answer questions. Thank you for your attention.